My name is Jonathan Butler, and I am a medical sociology in the Department of Family Community Medicine and also a cardiology. And I'm here with my colleague Terry, and we'll be hosting this Social Determinants of Health session today. And very excited to be able to listen to some of these outstanding projects that some of our presenters are working on. And so, not to belabor our time, we have a short amount of time. And so each presenter will be given 5 minutes to present their posters, and we will make sure that we are within our 5-minute time frame. And so at 4 minutes, we'll just slightly give you a nudge to let you know to wrap up. And then at the end, we will have a question and answer period where everyone can chime in and ask specific questions to our presenters. You can also provide your questions in the chat so that we can keep up with, document the questions that were asked today. So with further ado, we'll go in the order as indicated in the chat. So we'll begin with Sarah Amare, and we ask that you would just briefly introduce yourself and begin your presentation. And again, each presenter has about 5 minutes to present.
Hi, everyone. My name is Sarah Amare. I am an NSF Reps Fellow at the University of California, Berkeley, conducting research on plant pathogens impacting pear and apple producing crops. Prior to the project I'm working on currently, I worked on this project I'm presenting today, looking at the Emergency Food Assistance Program in the Bay Area, California, during the COVID-19 pandemic in 2020. So food insecurity is a prevalent issue for many people throughout the United States of America, and a major concern for Bay Area residents due to high cost of living and food deserts. Since the pandemic, an array of underlying issues, especially economic hardship and health, have been exacerbated. Fresh Approach is a Bay Area nonprofit organization that empowers families to make sustainable lifestyle changes by expanding their nutrition and cooking and gardening skills, by boosting access to affordable produce sourced from local farmers. In 2020, Fresh Approach established the Farm Fresh Food Relief Program, which I'll be referring to in the poster as FFFR, funded by the United States Department of Agriculture, the USDA. So this program enabled fresh produce to be purchased from local farms to be aggregated at food hubs, which are organizations that support small farms by serving as distributors and marketers. So the food hubs were the drivers of this program, sending food boxes to community-based organizations. And these community-based organizations were selected in low-income areas of the Bay Area, California, where food insecurity and nutrition were major concerns. So the community-based organizations distributed the produce boxes for free to families in need within their community. For this project, we analyzed this program through 2 case studies, highlighting the impact at each scale, primarily centered around the food hubs, by interviewing and surveying key stakeholders, including the distributors, community organization leaders, and the recipients of the food boxes, to gain a holistic perspective of the system. So the overall results of the program: they delivered over 60,000 produce boxes between April to September 2020, invested over $1.5 million into local farms, and worked with 44 Bay Area organizations. With the 2 case studies highlighted here, they were both from the same food hub, the Agricultural Institute of Marin, referred to here as AIM. They worked with 8 community-based organizations, 2 of which were Clinic by the Bay and Enriching Lives Through Music, which both serve low-income Latino Bay Area participants with weekly and biweekly food boxes. So the results showed here that the participants, a large majority, found the boxes helped them have a healthier diet, while all participants found that the boxes helped them save money on groceries, go to the store less often, were accessible, and they would want to receive them again. So this program also allowed the community-based organizations to start up programs and provide more resources with community support around the needs of food insecurity, which they became more aware of that their participants were experiencing during the program, to continue that support when it ended. This program was unique from other USDA contracts because it was centered around themes of fair pay for farm workers, food quality, community engagement, and equity in food access. This data showed how effective the collaboration with community-based organizations and local farmers was to the program, as well as how critical food assistance programs can be in alleviating food insecurity. This short-term assistance also had monumental effects on the communities that have faced historically have faced disparities in health during one of the hardest times that this country has endured. This program also demonstrated the success as well as the importance of investing in communities of color as workers, recipients, and community organizers. And it's essential that consistent funding is encouraged to improve the resilience of sustainable regional food systems, food equity, and overall health of all communities residing in the Bay Area. Before I conclude, I'd just like to thank the University of California, Berkeley School of Public Health for the opportunity, my mentors, Rachel Abraham and Karen Sokol Gutierrez, and our collaborators, Christopher Bacon and Andy Olaf. Thank you, everybody, for your time.
Okay, thank you. You have 10 seconds left, so that's perfect. The next presenter is Travis Curtis.
Were we going to do questions as well? I don't want to cut in too early.
We're actually saving questions to the end, and those of you who have questions, you can also put them in the chat, but I want to make sure that everyone has the opportunity to present. Thank you.
Hi, this is Travis Curtis. I believe Omid Buzarpour, the UCSF student, will be presenting the poster.
Yes, I will. Sorry, there was it's because Travis is the first author on our poster, so that's why he was listed, but I'll be presenting today.
Great. Welcome, Omid.
All right, well, I guess no better time than the present. So my name is Omid Buzarpour. I'm a fourth year medical student at UCSF, working in conjunction with Travis Curtis, a medical student from Albany Medical College, and the rest of our team, which you can see listed on the poster. Our project was titled Pre-Hospital Chest Pain Management Disparity Based on Homeless Status. And so we kind of wanted to look into possible disparities in care. And I think this came from a place of knowing that homelessness and people being unhoused is a big problem throughout the country, but particularly in San Francisco. And those who are experiencing homelessness often have high burdens of chronic illness, are at high risk for death and disability. And then also their often only way to access care is through the emergency department and also through emergency medical services or EMS. And so we looked, and although there's a lot of documented research on disparities in care in the hospital, in the emergency department, and there's some qualitative research on how people who are unhoused feel they're treated in these settings and also in the EMS setting, there's less kind of hard data in that area. And so that was the purpose to further characterize disparities in care in that area. And so what we did is we took all the 2019 data from a single 911 provider in San Francisco, which was 630 records, essentially 630 runs, which had the primary impression of chest pain, or CP as it's indicated in the poster. And so we compiled all of these EPCRs, and we kind of filtered through them to determine whether the patient was indicated as unhoused or housed, and then also to kind of see what interventions were given. One of the reasons we picked chest pain was because it's a little bit more standardized in the way things should be done for it. And also it's one of the more common complaints, and one that is kind of associated with chronic disease that we know is kind of more prevalent in unhoused patients. And so you can see the patient characteristics, but I think what's really interesting is looking at the results across all these different interventions, whether IV attempts, IV established, 12-lead EKGs, aspirin, aspirin PTA is aspirin prior to arrival, nitroglycerin, analgesic medicine, and whether lights or sirens are used. And although they weren't all statistically significant, we can see that there's a difference or disparity in all of them. And in some kind of key ones like aspirin, nitroglycerin, and placing an IV, which are all kind of core steps in chest pain management, those were statistically significant, lower in patients who were noted to be unhoused in the chart. And so kind of conclusions going off all of this is that people experiencing homelessness were less likely to receive aspirin, nitroglycerin, and have an IV placed. None of them received analgesic medication, but that's something that is relatively infrequent. We did notice that there's practically no difference in 12-lead EKG usage, which is something that's really drilled into the protocol for chest pain. And so it's kind of good to see that when protocols are really strongly stated, some things make it through, but it seems that obviously there's still a disparity there. And so it seems like there's a disparity based on this data, at least. We recognize that like this is a relatively limited scope of patients that we looked at. And so we're hoping to, kind of do further research in this area to further assess disparities and then maybe also investigate possible solutions that can help close this gap.
Wow, that may be record time. You have about a minute and 30 seconds, so we'll have a lot of time for discussion at the end. The next presenter is Alice.
Waiting for my poster. There we go. So hi, everyone, and thank you, Jonathan and Terry, for moderating the session, and to everyone who is joining us in the session today. My name is Alice Guan, and I am a PhD candidate in the Department of Epidemiology and Biostatistics here at UCSF. And today I'll be sharing findings from a research project exploring the association between ethnic enclaves and healthcare accessibility across 5 states. I'm here representing my study team, which includes collaborators spanning 10 institutions across the US, and without whom this work would not have been possible. So to dive right in, ethnic enclaves are theoretically defined as socially and economically unique geographic areas where particular ethnic groups are spatially clustered. Although ethnic enclave residence has been hypothesized to protect individuals by increasing availability to linguistic resources and also supporting the preservation of cultural identity, evidence of ethnic enclave effects on health have been really mixed. As an example, residence in both Asian American and Hispanic enclaves has been found to be associated with consumption of healthier diets and also better self-rated health. But on the flip side, residence in enclaves has also been associated with increased tobacco use for Asian Americans and also higher levels of obesity for Hispanic populations. And all that being said, one of the challenges of doing work on ethnic enclaves is that there's very little consensus on how to quantitate these measures, which could really offer an explanation to the inconsistency that has been observed across studies that have looked at associations between enclaves and health. There's also very limited description of the neighborhood built and social environments of ethnic enclaves. So the first part of this study really focuses on describing the characteristics of both Asian American and Hispanic enclaves. And similarly, while there's been a healthy body of research that focuses on individual health behaviors and outcomes based on residence in enclaves, there's less research that is done on upstream factors that can also influence health. So the second part of this study focuses on describing associations with geographic healthcare accessibility, which really is an underexplored upstream mechanism, which has been found to be an important predictor of preventive care and also improvements in health. So what did we do? So we first used a principal components analysis to develop a census tract measure of both Asian American and Hispanic ethnic enclaves using data from the census and also the American Community Survey for the years 2000 and 2010. And these data were pooled across 5 states which have high Asian American or Hispanic populations. I've included a link to the working paper describing the development of the ethnic enclaves in more detail for anyone who's interested. And then we evaluated differences in built and social environment characteristics between Asian American and Hispanic enclaves versus non-enclaves in 2000 and 2010. And finally, using 2010 data specifically, we explored associations between ethnic enclaves and a measure of geographic primary care accessibility using multivariable logistic regression models. This measure was developed to encapsulate geographic data on the supply and demand of primary care physicians. And so what did we find? So as you can see in table 1, there are similarities in characteristics of both Asian American and Hispanic enclaves versus non-enclaves. So for example, both had higher proportions of immigrants, crowded housing, and also proportions of younger residents. However, we also found that there were some differences. While Asian American enclaves had lower crime, poverty, and a proportion of uninsured individuals compared to non-enclaves, Hispanic enclaves had higher proportions of these elements compared to non-enclaves. And in table 2, we show the results from our multivariable models, and we found that Asian American enclaves had higher odds of geographic primary care accessibility compared to non-enclaves, and that this association was similar in tracts with and without persistent poverty. For Hispanic enclaves in metropolitan census tracts, we found that enclaves had lower odds of geographic primary care accessibility, and this association was modified by persistent poverty. And we didn't find accessibility differences for Hispanic enclaves versus non-enclaves in rural census tracts. So overall, our preliminary conclusion from this study is that differences in our findings between Asian American compared to Hispanic Latino enclaves could really reflect differences in migration and settlement histories, structural racism, and economic disadvantage. And these all may contribute to health behaviors and outcomes for these populations. Thank you so much.
Wonderful. You all are amazing within your time frame. Excellent. The next presenter is Evelyn.
Hello, my name is Evelyn Tran. I am a research intern in the G research team led by my PI, Dr. Jane G, and this is my project. To lay the foundation of the study, older minority adults face a large burden of chronic conditions, yet clinically, they endure poor care and experience worse health outcomes relative to older adults. To address this, social support, defined as the emotional and practical support individuals perceive receiving, has been identified as one of the critical domains for effective multimorbidity management. And so the objective of this study was to analyze this influence of social support on chronic disease management and explore through photographs received from participants how this social support could be visually depicted. In order to execute this, older adults 65 and above with 2 or more chronic conditions based on the Elix-Hauser Comorbidity Index were recruited from 2 UCSF primary care clinics, and they had to have either spoken English, Spanish, or Chinese. Semi-structured interviews were then conducted virtually through video conferencing such as Zoom or phone calls, and afterwards, the participants were given photo prompts at which they were asked to take photographs and submit them to the team. For the data analysis component, the interview transcripts were coded using a thematic analysis approach with a framework matrix, and the photographs were coded with a 2-step systematic process developed by the team, which codes the visual content of both the foreground and background. In figure 1, this offers some insight into how this technique is conducted. You could see the plate of food captured by the red box. This is the foreground of the image, which is what the photographer has intended to capture and is also the focus, and everything outside of that box is the background. For our results section, table 1 shows the characteristic breakdown and demographic breakdown of our study participants. The average age was 76, it was 47% female. And below that, you can see the racial ethnic breakdown as well as the percentage of participants with 2 to 4 versus 5 or more chronic conditions. 4 main themes were deduced from the study. The first one was the beneficial effects of adequate family and non-family support on chronic disease management. In the example below, the female participant is talking about an example of non-family support in which she is referring to her caregiver and says, she comes to my appointments because my English is not so good, or hers is. And so the main key takeaway from this example is that the participant faces a language barrier. So this support that she reports receiving is almost necessary for her disease management due to the communication barriers that exist between her and her physicians and her care team. In the second theme, the negative impact of COVID-19 on support networks is also conveyed. The male participant is referring to his sister who lives in Taiwan in this example, where he says, right now, I wish I could go visit her, but I can't because of the pandemic. And in this situation, his inability to visit her causes a strain in this relationship that he reports, factoring into his anxiety that he subsequently talks about. And in this case, it's just one avenue of the many ways that COVID-19 has affected support networks within many individuals. And the third theme, the consequences of insufficient support on health and well-being are depicted. The female participant is being prepared for surgery by her physician, in which her physician asks if she has any family. And she confides that it's not easy because I'm pretty much on my own. I don't have any family here. And in this example, the participant is an immigrant from Mexico, resulting in her being away from her support system. And this separation poses challenges in a health context for her. And the fourth and final theme relates to the photo component of the entire study, in which it showed that elements of social support can be conveyed through images of family members and friends, video conferencing with individuals, and multi-person dining table setups. Figure 2 shows a table with many framed images of loved ones, indicating the potential existence of a robust, strong family network system and friend network system too. Figure 3 is a participant sitting in the back of a kayak taking a picture of his wife as they're kayaking on a lake. Figure 4 is the participant Zooming with their family members during COVID-19. And this is an activity that has risen in popularity with the onset of the pandemic, given that it allowed many individuals to socialize while being in accordance with social distancing protocol. The fifth and final figure is something that's really interesting, as there's no physical presence of any person in this photo, but it's an indirect measure of the existence of social support. There is a dining table and food prepared for multiple people. And this was a very common way to visually convey social support that we found, as eating together was a very universal shared experience that participants engage with people that were important in their life. And this type of example can also be seen in figure 1, as there's a shared plate in the middle, as well as 4 plates in the background. In conclusion, social support of varying sources and intensity differentially affect chronic disease management. And these photographs that were received from participants may provide additive visual data from their unique perspective. That concludes my presentation. I'd like to acknowledge all of the members from the G research team. This project would not have been possible without them. Thank you very much.
Thank you, Evelyn. And our next presenter is Ava.
Great, thank you for having me, and thank you all for your attention today. My name is Ava Yap. I am a general surgery resident at UCSF, and I'm here today to give my presentation on the neighborhood level socio determinants of health that are associated with greater postoperative complications in children from a tertiary hospital in California, which is UCSF. Just as some background, we know that about 10 to 20% of health outcomes are determined by the care that we give in the medical system, while the rest actually results from our social determinants of health. So it's important to know what affects the children that are undergoing surgery outside of the hospital. Previous studies have found that low coverage with insurance portend a higher risk for perforated appendicitis. And in defunded Medicaid states, there's lower access to neonatal circumcision. Furthermore, a recent study had found that Black children are 3 times more likely to die from surgery than healthy white children. But unfortunately, it's quite hard to tease out modifiable social determinants of health to cause change. So we decided to look into an area-based social determinants of health called the Socio-Vulnerability Index, or the SVI. The SVI is a census tract level indicator that marks the overall vulnerability under 4 themes, including socioeconomic status, household composition and disability, minority status and language, and housing type and transportation. It's a unit that's listed as a national percentile ranking, with 1 being the most vulnerable and 0 being the least. And this is marked across both nationally and per state as well. We use the national ranking here. In terms of our methods, we utilize the National Surgical Quality Improvement Program Pediatrics Database, which UCSF is a part of. And we look at pediatric patients undergoing NSQIP eligible surgery with ASA class 1 and 2. So we focus on the healthy children. Our primary predictor were patients' geocoded SVI, and the primary outcome was serious postoperative complications within 30 days. This was the binary outcome and a composite of postoperative mortality, readmission, and reoperation. In terms of the covariates of our model, we included age, gender, race and ethnicity, language preference, insurance status, contamination, sepsis, and distance from hospital. And we did use the multivariate logistic regression model to conduct our analysis. We found that the overall high SVI, which was defined in our study as equal or greater than 90th percentile, had a significant odds ratio of any postoperative complication at 1.59. And interestingly, when we divided up the sub-themes, we found that socioeconomic status was the only theme in the SVI that was also significantly associated. As you can see here, the other sub-themes, including minority status, household composition, and housing arrangement / transportation, were not significant. We also did look at distance from the hospital as one of the secondary outcomes, and this was not significant either. So I think it's interesting to note that with this particular indicator, we were able to tease out some of the etiologies that make up a patient's socio-determinants of health. And we did find that overall, high socio-vulnerability is associated with poor surgical outcomes in apparently healthy children, even after adjusting for potential co-founders. We did find that neighborhood socioeconomic status was independently associated with serious postoperative complications, and this could potentially be a target for future interventions where we could identify those who are at high risk for socioeconomic vulnerability and assist them with healthcare programs or community outreach programs. So in conclusion, we did find that area-based socio-determinants of health did seem to play a role in postoperative outcomes. Thank you, and I'm happy to take questions.
Thank you, Ava. And we will take our questions after we hear from Lucy. Last but not least, Lucy, please unmute yourself and you can begin. Thank you.
Hi, everyone. Thank you for the opportunity. My name is Lucy. I'm a second-year medical student. I'm here to present my project from the California Statewide Survey of Homelessness, which is a very large statewide project, and this is a sub-study of that. So first, for a little bit of background, we are looking at the bidirectional relationship between homelessness and incarceration. According to the most recent data, there's over 565,000 California residents under correctional control and over 161,000 residents experiencing homelessness on a given night. So these are two very big public health crises that our state is facing. And prior research has established the bidirectional relationship between these two crises, with formerly incarcerated people 10 times more likely to experience homelessness than the general public, and 15% of currently incarcerated people experiencing homelessness in the year leading up to the incarceration. So the goal of our sub-study is to understand the nature of this bidirectional relationship. And since incarceration represents an opportunity for intervention for people who are unhoused, we are also seeking to investigate what kinds of housing and placement assistance people are receiving when they are discharged from incarceration. And we're also looking for opportunities for policy change to interrupt this cycle that is ongoing for a lot of Californians. So as I alluded to before, this is a sub-study of the California Statewide Survey of Homelessness, which is a mixed method study on adults experiencing homelessness in California. So the first part of this survey is a structured questionnaire where we had a team of researchers go out and give this survey to samples of unhoused individuals in 8 different counties. So they would go to encampments, shelters, SIP hotels, and car parking lots to sample unhoused individuals. And then within the individuals that were surveyed, a subset of individuals were identified as qualifying for our sub-study. So these individuals were people who had been incarcerated for 3 months or more. And for these individuals, we gave an in-depth qualitative interview that mainly focused on their trajectories through becoming unhoused and being incarcerated. And then finally, we coded these interviews using Deduce software. So So far, we have identified 3 main themes that have come out of this qualitative sub-study. So the first is perceptions of the homelessness and incarceration relationship. When asked if homelessness contributed to incarceration, unsurprisingly, the vast majority said yes. And many of them explain this as harassment by law enforcement leading to incarceration, and after release from incarceration and being put on parole or probation, having difficulty following the rules of parole and probation due to being unhoused. So here's a couple representative quotes that I pulled. One of them describes missing a court date because he lost his ticket during an encampment sweep by law enforcement. So he was not able to make it to his court date, and later on he was incarcerated for missing the court date, which just describes the systemic nature of the difficulty following rules of parole, and how law enforcement contributes to that difficulty. The second quote is about harassment, which was a very common theme among our participants who mentioned being harassed because of their appearance. And finally, when asked if incarceration contributed to homelessness, some said yes, but some also said no. And many described the difficulty finding a place to rent and finding a job due to their criminal record. The second theme that we found is the role of substance use. The vast majority, I think all of our participants actually mentioned substance use in some way during their interviews. So despite the common perception that substance use causes homelessness and incarceration, a lot of our participants actually described the relationship going the other way around, where they began using substances or started using more substances due to the adverse circumstances of becoming unhoused and becoming incarcerated. And then following that, the criminalization of substance use and drug possession itself while unhoused. As for unhoused individuals, stops by law enforcement and encounters with law enforcement are really common, whether it's through sweeps or through just encounters on the street. And many of our participants described substance use or possession as being one of the biggest reasons that they're incarcerated when having encounters with law enforcement, even when the encounter is for an unrelated reason. So here's a representative quote from that. This participant says, they profile you and you look up and you have a few possession charges due to that because they just pretty sure everybody got at least 2 possession charges around here. So it just describes the prevalence of substance use and possession charges for unhoused individuals. And finally, the third theme is pretty straightforward. Regarding services received during reentry, we asked this of all participants, and the vast majority received no services upon discharge, and not even being asked if they're unhoused. So finally, in conclusion, we have a couple of policy implications. Firstly, is the need for the reform of law enforcement practices, particularly in regards to substance use and substance possession, as well as police encounters in general. And secondly is developing a more robust system of service provision to end the incarceration to homelessness pipeline. And finally, I'd like to thank my mentors, Dr. Margot Kuchel, who's the leader of the California statewide survey, and Dr. Dallas Agustin.
Thank you, Lucy. And a shout out to all of our presenters who did an exceptional job presenting their work, and congratulations on you for doing such a phenomenal job. I want to invite all of our presenters to show your screen, and I want to open up the floor for any questions from those that are in this Zoom call, and feel free to unmute yourself and you can ask your questions directly. You can also enter your questions into the chat as well. I think Alice has a question for Lucy. How do you think the recent policy decision regarding marijuana will influence participants in your sample? And the question is also in the chat.
Hi, thank you, Alice, for asking that question. That was definitely huge news in this realm. I think, regards to marijuana in particular, my hope is that that will be erased from a lot of people's records soon. But I think that most of the participants that we talked to directly their substances were more with other substances like stimulants or opioids. So that continues to be a big problem.
Thank you, Lucy. Any other questions? Again, feel free to unmute yourself and you can ask directly. You can ask a general question to the entire group here, and the presenters can ask questions to other presenters as well. As we formulate our questions, I have a question for Sarah, and her work on food security is certainly an interest of mine. And I'm wondering, I know that your work was done at the initial stages of the pandemic, but in your conversations with communities, do you feel like the demand is still the same or more? And what are some of the things that are in place to ensure that these communities are able to continue with their food programs?
Thank you for your question. While talking to recipients of the food boxes, people were actually, I think early on in the pandemic, receiving also other resources that were there. People, when we interviewed them, was a year later after the initial program was implemented, so in 2021, and people very much still wanted to receive food boxes. I think after the program ended, the community organizations that we interviewed realized how big of an issue food insecurity was within their participants, and they tried to work with people who were local within their community to give people more support and resources and kind of open up those conversations to continue after the program ended.
Thank you, Sarah.
Yeah, no problem.
I want to, as folks are formulating their questions, I want to highlight the use of qualitative methodologies during these presentations. There's a good mix of qualitative, quantitative. So I just wanted to highlight that. There's the question from Stuart. You have the floor. You can unmute yourself.
Sorry, I unmuted and then muted right back. Thank you everyone for your presentations today. I have a question for Ava Yap about her study on social vulnerability index and the pediatric hospital complications. So the hospital complication data that's UCSF, a hospital, UCSF pediatric patients who were then discharged, and then there was follow-up to see if there are complications, right?
Yes, that's right. So the way that the NISQIP, oh, sorry, go ahead.
Oh,
Yeah,
so my question is, since those patients would be clustered in different areas, like different census tracts or different zip codes, do you need to do some sort of cluster data analysis adjustment in your regression model? Some kind of cluster logistic regression like GEE or a mixed model?
Yeah, I think that's a really great question. So I think the way that we were thinking about it is that UCSF was considered a sort of a regional referral hospital. And so in terms of the distribution of the patients, they sort of spanned, it seemed like it represented counties all throughout California. And so we had not thought about clustering in terms of finding hotspots in different neighborhoods, mainly because it seemed like there was a pretty wide distribution. So if we were to cluster, I feel like there would be, I think each subgroup would be quite small in that sense. We are currently working with other institutions to try to broaden our encatchment area. And so I think if we were to start including multi-institutional data, then we would think about clustering by institution. But I don't know if that answered your question.
Yeah, so thanks. I think that's an important point that you will have some areas that with quite a lot of patients, and it'll probably be the ones closer to UCSF. And then because it is a tertiary care center, you're still going to get distributions of a small number of patients throughout the state. And the reason I'm asking is because I've been asked similar things with similar kinds of approaches where you have an area level measure and you want to assess the impact of that, and you have clinical data rather than like census data where you have representation from each of the areas. So you may find that when you go to submit your paper for publication or something like that. So you may want to see how robust or sensitive your results are to a different type of analysis. But thank you for your work and for your question, your answer to my question.
Absolutely. And thank you so much for that input as well. That's really helpful for us to consider, especially as we get to higher levels of hierarchy in terms of the levels of data that we've included, both in the individual level and also the neighborhood level.
Wonderful. We have two questions in queue. One is from Eric Smith and the other is from Lucy. We'll start with Eric.
Hi, I'm actually like, I know sake of time, I have questions for like literally everyone because this is like all work that's so important to what I do. But
so Eric, before you proceed, you can certainly input your questions to everyone in the chat.
Okay. All right.
Ask your two most important questions.
Sure. No, I was just gonna do one. Evelyn, I think that's your study was the one about you did a qualitative study in social support, and I just thought that was such a the method is like really inspiring. I thought it was really cool. Just first off. Second, my question is, do you have any data or do you know anything off the top of your head about pictures that people took that don't reflect good social support? And how that looks different from what you decided to present to us today?
Yeah, that's a fantastic question. So there was like a lot of variability within all of the photos submitted by the participants. The first two participants in our study was before COVID-19 occurred. And so we had to like amend how the study was conducted after the pandemic. And so the first two participants were when researchers visited the houses themselves and then took photos themselves. And then for one of the participants, that lack of social support was kind of indirectly conveyed through the entire layout of her house, and that there were a lot of single room setups, like for example, like a very small table that was only meant for one person. There was quite a bit of clutter in some of the spaces, and yeah, those were some like indications of it. But like given like the nature of research and everything, it was hard to like conclusively deduce that the layout of that was attributed to social support because it's such a nuanced state and there could be so many like confounding variables and such. But yeah, it's a really great question. I definitely think that it can definitely be visually seen, but it's hard to conclusively say that it is unless you bring it up in conversation with the participant.
Great. So the next question comes from Lucy. Lucy, would you like to read your question to Omid?
Sure. I just had a question about like follow-up data post the EMT or paramedic interaction, like following the admission to the ED, were the unhoused patients more or less likely to be admitted or diagnosed with cardiac issues, or if you just have explored that at all.
Yeah, so that's a really great question, a train of thought that we thought about. We had some trouble with navigating the two different medical record systems actually connecting the data from the ambulances to the data in the ED, although we have access to both data sets. So we don't actually know follow-up data for these patients, but there have been studies on how unhoused patients are treated in EDs in different parts of the country, including, I think there was a study out of San Francisco. As you might expect, there are disparities in care in terms of like whether people are admitted or not, and how like quickly, oftentimes what they measure will be the time to diagnosis or like the time to getting a catheterization or other treatment, and there are disparities there.
Great. I like how you all are asking each other questions. And I know Alice has a question for Ava. And so Alice, would you like to read your question?
Sure, yes. This is kind of a two-part question, but I had a question specifically about the SVI index. So the factors that went into the SVI seem to be highly correlated. So my first part of the question is, how did you decide which to include specifically to account for potential correlations between these factors? And likewise, which social determinants of health did you prioritize for selection?
Yeah, great questions. And I think always with the retrospective cohort study, it's hard to make those associations and the directionality with those associations. So the SVI has actually been around for a while, and it was initially created by the CDC to assess disaster preparedness in communities. And so the indicators that actually go into it under the 4 themes all have kind of like real statistics. So for example, the socioeconomic status is made up of 4 markers. One of them is, percentage that's impoverished, the other one's percent that's employed. And so I think they're easily measurable, and the way that the SVI composite score is calculated is to include, it basically weight all of these. There's actually 15 variables that are compiled into the 4 sub-themes. And so I think while they may be correlated, I think each measure does actually look into or evaluate a certain characteristic of the neighborhood. And so it is a validated way of assessing just like the general socio-vulnerability of a neighborhood. And the other question about the individual level determinants of health that we prioritize to select, we knew that even though the neighborhood and the individual level characteristics may be correlated with each other, there have been previous studies that show that they are still distinct enough from each other that they should be both included into the model to better assess how each factor plays into a person's determinants, overall determinants of health. And so what we had found was that there is actually not as much collinearity as we would expect between the individual level and the neighborhood level SVI. And so that is why we included, race, insurance status, language preference, which is all a part of the individual versus the neighborhood. So I don't know if that answered your question.
She says yes.
Okay, great.
Not yes. Okay, so we are at 11:57. Our close time is at noon, but I wanted to give an opportunity to our presenters to just give us a 20-second takeaway from each of you about your project, and then we will conclude our session. So you all can just jump in. Or I can suggest names first. Why don't we start with Lucy?
Okay, 20-second takeaway. I'll just summarize our 3 main themes. That homelessness contributes to incarceration due to harassment by law enforcement, difficulty following rules of parole, and the criminalization of substance use and drug possession while unhoused. Secondly, homelessness and incarceration are a cause of substance use. And thirdly, the vast majority of unhoused individuals who are incarcerated receive no services upon discharge from incarceration.
Thank you. Ava.
Great. Thank you so much, everybody, for your wonderful questions. This was a scintillating conversation. I would say that my 20-second takeaway is that the neighborhood level socio-determinants of health do seem to play a role in otherwise healthy children who are undergoing pediatric surgery in California. And specifically, the neighborhood level socioeconomic status does seem to play a role. and kind of trying to answer Eric's question last minute. We think that perhaps, in terms of the makeup of California's demographics, we do see that patients are generally more diverse, and there might be, a component of acceptability in the sociodiversity, but there is a large disparity in wealth that occurs, especially between rural and urban settings.
Evelyn.
To keep it short and simple, contextual factors are critical for chronic disease management, and they vary pretty drastically for each patient. And social support is really critical, especially when you're looking at the population of older minority adults, and understanding that can really help you tailor to the care in a clinical setting.
Alice.
Yes, so 20 seconds. I think the effects of ethnic enclaves on health are complicated, but knowing more about their characteristics can help us to consider potential mechanisms through which they influence health. So kind of speaking again to Eric's question, including potential mechanisms could be like exploring the effects of historic investment or disinvestment in particular neighborhoods based on ethnic composition.
Travis or Omid.
Thanks. I think what we would say is that there is evidence of disparities in care for unhoused patients in the EMS setting. Knowing that this is a place where a lot of people who are unhoused have to receive their care, investigating this further and then looking for ways to improve the disparities is an important line of investigation.
Last but not least, Sarah.
I'll keep it quick. This project showed the importance of investing in communities of color, community-based organizations, and food assistance programs to alleviate food insecurity.
Thank you all for a wonderful presentation, and wish you well in your future pursuits. Have a good day and weekend.